Good afternoon. Welcome to Medical Grand Rounds. We've got a small but mighty crowd here in HSW, and typically we've been having 100 to a few hundred people online. So we'll see how that ratio goes over time. For those who are interested in coming, there's always good food and good company. I'm Bob Wachter. I'm chair of the Department of Medicine. The ground rules for those of you watching online are there, and you probably know them. Lakshmi will be monitoring the question and answers. When we get to that, CME is available. Stay on at the end for that, and closed captioning should be available as well. Reminder that we suspend grand rounds for the summer after the end of June. We will do a special one if there's something major that changes, probably most likely in COVID, but otherwise we will come back right after Labor Day. Also, if you're following our schedule, we have made a change for the last grand rounds of the academic year, June 30th, which was scheduled to be a neuro session, but we're going to spend the time in a panel discussion about gun violence for obvious reasons. Today, our talk is called Liver Transplantation, Where Are We Now and Where Are We Going? It's an incredibly exciting topic and one that UCSF has unique expertise and impact in. We have two speakers. Danielle Brandman is Assistant Professor of Medicine, a hepatologist here. She specializes in patients who need liver transplants. She's also an outcomes researcher in addition to her clinical work, who studies mostly non-alcoholic fatty liver disease and outcomes of that after transplantation. Danielle received her medical degree in New Jersey at New Jersey Medical School. She then came here to UCSF, where she did residency, GI fellowship, hepatology, transplant hepatology fellowship, as well as a master's degree in clinical research. She'll be joined by Shareef Syed, who's a general surgeon who specializes in abdominal transplantation. He's associate director of the UCSF Surgical Skills Center and director of Abdominal Transplant Fellowship Program. He trained in Leicester in the United Kingdom, trained then in the National Health Service, then came ultimately to UCSF to complete his residency in general surgery and an abdominal transplant fellowship. And he is a specialist in doing the kinds of surgeries, as well as several others that we'll hear about today. So I think, Danielle, you're going first? Or? Great, thank you.
All right, well, thank you so much for that introduction, and thank you for the invitation to speak to the group, those of you here as well as many of you online. So, just to start out, I want to mention that transplant is a team sport. It sometimes feels as chaotic, but maybe not quite as cute as the Puppy Bowl. But I do think our team in particular is really as elite as the Golden State Warriors, at least how they played in Game 2, maybe not last night. But we do have a deep bench and a really fantastic team. Just to briefly mention the learning objectives that we'll cover today will be to recognize the common causes of chronic liver disease in non-hepatology settings, to understand the strategies to increase transplant rates and improve the likelihood of a successful transplant, and finally, to appreciate the long-term outcomes of liver transplant recipients. And to cover these objectives, I'll be dividing the talk into the pre-liver transplant period, which is really the opportunity for disease recognition and intervention, pre-transplant, talking about the current indications for transplant and candidate selection, liver transplant surgery itself, which Dr. Syed will discuss, which will involve donor selection and intraoperative management, and then finally we'll conclude the talk with long-term post-transplant outcomes. So, NAFLD is really the other pandemic that has been coexistent with COVID and present before COVID, and unfortunately will be with us long after COVID is hopefully gone, or at least less of a threat. And we know that it affects a really large swath of the population. 25 to 30% of the US population has NAFLD, fatty liver disease. Almost all patients with diabetes, 40 up to 70%, may have NAFLD and they have a higher risk of NASH, the more aggressive form of fatty liver. About 30% of patients with NAFLD will have NASH, and up to 20% of those patients may actually go on to develop advanced fibrosis or cirrhosis and then be at risk for complications of end-stage liver disease. So how can you as a non-hepatologist recognize these patients? Because most of these patients don't actually live in the hepatology clinic. We have to think about their risk factors, such as the metabolic syndrome comorbidities. And when you recognize that they have fatty liver, it's very important to try to do a fibrosis assessment to determine, are they at risk for advanced fibrosis? And one of the ways that this can be done in primary care is by using the FIB-4 index, which is calculated using this formula here. Don't worry, you don't have to memorize it. You can find it online. And if you actually practice at Parnassus or Mount Zion or Mission Bay, there's actually a smart phrase in Apex that Rena Fox and I added that will actually pull in all of the data needed to calculate the FIB score and provide you with guidance. If your patient falls into the high-risk category, it is important to link the patient to hepatology for further care, because we know that patients who have cirrhosis, who are followed by a specialist, are more likely to be adherent to quality measures such as HCC surveillance, and this actually reduces liver-related morbidity and mortality. So use the FIB-4, it's easy. The other liver disease that we've got to talk about is alcohol-associated liver disease, or ALD. This liver disease accounts for half of all liver-related deaths worldwide. And what we're seeing in this graph is that the younger patients, those in the age group of 25 to 34, are really having greater increases each year in death related to alcohol use disorder, alcohol-related liver disease, and cirrhosis. So I think this really tells us that both non-alcoholic fatty liver disease and alcohol-related liver disease are huge public health problems. Because of this, it's very important that the non-hepatologists and the hepatologists and gastroenterologists are screening all patients for alcohol use disorder. And again, there are simple tools out there. The tool that is recommended is the Audit C, which is a brief 3-question tool, which actually performs better than the CAGE questionnaire, which I learned in medical school. Not sure if they're still teaching that. But it can actually detect hazardous use. And if you do detect hazardous use, this is your opportunity to further evaluate the patient and potentially intervene and refer them for treatment so that they don't end up in my clinic or under the knife with Dr. Syed. So when we're managing patients with alcohol use disorder, I think sometimes there can be hesitance in patients who do have more advanced liver disease. But we should be telling all of these patients that they need complete abstinence from alcohol. If they're able to abstain from alcohol, this reduces the risk of variceal bleeding, encephalopathy, ascites, death, and hepatocellular carcinoma, or HCC. Now, we know it's not enough just to tell patients, stop drinking. It's important that we also provide them with the tools to actually support their abstinence in relapse prevention. And this is in the form of integrated multidisciplinary care, as well as use of pharmacotherapy. And the 2 agents that may be able to be used in patients, even those with advanced liver disease or alcohol-associated hepatitis, are acamprosate and baclofen. If you're not comfortable using those medications yourself, refer the patient to an addiction specialist. I think the key here is really providing the patient with the tools that they need for success and to try to improve their overall and liver-related outcomes. The other thing I'd like to mention is that there really is this narrow window of opportunity for liver transplantation in patients who have cirrhosis. And this graph is really showing what a possible trajectory might be for a patient with liver disease using the MELD score, with a MELD of 6 being pretty healthy, normal liver function, and a MELD of 36 being very sick, like our patients in the ICU. Now, decline in liver function is very rarely linear. What happens more often is that we have these decompensating events and then followed by some recovery, followed by further decompensating events. And we see that there tends to be this narrow window of opportunity for transplant related to most patients needing a MELD score out here in the 30s in order to get a deceased donor transplant. Despite that, we really welcome and encourage early referrals to hepatology when they are compensated or they have a MELD score of 6. We can engage in guideline-based surveillance and also start to get to know the patient and prepare them for, if they decompensate, let's put you in the best place possible for transplant, try to overcome any barriers that may exist. Definitely, after their first episode of decompensation, they must be referred to a hepatologist, and we have to be thinking about liver transplantation. The other opportunity these patients may have is living donor liver transplant, where if they're listed for transplant, then it doesn't really matter where their MELD is. But if we're not referring them early, we may be taking away opportunities from these patients. So I will now talk about our liver transplant candidates and some factors that may affect candidate selection. Before I do that, I do just want to briefly review some recent temporal changes. We know that transplant has really grown and outcomes have greatly improved over the past 30 plus years, but there have been additional changes that have occurred over the past 10 years or so. We're seeing that fewer patients are listed for liver transplantation, but more actually end up getting transplanted. We are seeing increased rates of combined liver kidney transplant. We are transplanting older patients, with twice as many patients being at least 65 as compared with 10 years ago. And we are seeing increases in both obesity as well as diabetes, so potentially making for a higher risk, more complex patient population. So there are many diseases we can focus on to talk about in transplant. I've already talked a little bit about fatty liver and alcohol-associated liver disease, and that's really what I'm going to focus on. But other areas include transplant oncology with HCC, colorectal cancer, liver metastases, and cholangiocarcinoma. And it's really the direct-acting antivirals to treat hepatitis C that has paved the way for these opportunities and to allow transplant to continue to grow and develop and evolve over time. Currently, we see that NAFLD and alcohol-associated liver disease are the leading indications for liver transplantation, with patients with alcohol-associated liver disease dominating in men, whereas women have NASH as a leading indication for liver transplantation. We're also seeing some changes in birth cohorts, and with some modeling that was done and observation of trends, we're seeing that patients who are in this youngest birth cohort, covers many different groups, Gen X, millennials, so I can't really name this birth cohort, except to say they're younger. We're really seeing these steep rises in liver transplantation for fatty liver disease plus hepatocellular carcinoma, and those trends are expected to increase. We're also seeing increases, though less steep, in patients with fatty liver disease as their indication for transplant without liver cancer. But I think really what this is going to translate to is that our patients with fatty liver who need transplant are likely to get younger and younger, whereas historically, this was an older group of patients. And that brings into account the fact that we have to monitor for disease recurrence and thinking about, can they develop recurrent cirrhosis? So we're not seeing much of that just yet. Looking at our older NASH liver transplant recipients, we know that they're sicker than the non-NASH patients. They have higher prevalence of coronary artery disease, diabetes, hyperlipidemia, hypertension. So again, you'd expect, well, this group sounds very risky for transplant. What are you guys doing? Well, to date, we're actually seeing that post-transplant survival in patients with NASH is equivalent to other indications for liver transplantation. And these are data from the large UNOS database that looks at national data in the US. There was a more recent study that looked at patients transplanted from 2008 to 2017, and it looked like there was a slight decrement in the early or the 1 year post-transplant survival. However, I would argue that 90% 1 year post-transplant survival is still excellent and is not a reason to not transplant these patients, but it is something that warrants further monitoring as we are transplanting more and more patients like this. If you look at the combination of NASH and age of at least 65, it does appear to increase the risk of mortality 2 to 3-fold. But again, when we're looking at such relatively low mortality, the outcomes really are still good. And when we know a patient is sick with a high MELD score, they will otherwise die without transplant. So there is still that survival benefit. Now, we do have some tools to try to improve the health of our liver transplant candidates and recipients, and sleeve gastrectomy, the bariatric surgery of choice in patients with cirrhosis, is an important tool for obesity management. Andy Postelt and one of our former fellows, Suzanne Sharpton, reported on our experience here at UCSF that included about 30 patients, and they showed that 88% of liver transplant candidates who had Child's-Pugh A or B cirrhosis were able to reduce their BMI to less than 40 and ultimately go on to have liver transplantation. The Mayo Group has reported on their experience in performing simultaneous sleeve gastrectomy and liver transplantation, and they've really had excellent outcomes. This is comparing their medical and their surgical weight loss group. What they've seen is that there's a reduction in post-transplant diabetes, hypertension, metabolic syndrome, and also sustained weight loss in this patient population. We have done a handful of simultaneous sleeves and transplants, but not yet at the volume that the Mayo Clinic is doing. So one thing that comes up in hepatology and transplant meetings very frequently is a debate. Should we transplant patients with alcohol-associated liver disease or non-alcoholic fatty liver disease? And I have participated in debates like this. In reality, this is not a real debate. Alcohol-associated liver disease and fatty liver are the present and the future of liver transplantation. These two diseases and the patients who have them really have so many things in common, and there's really a high degree of overlap, but we do tend to treat them differently, and unfortunately, the patients with alcohol-associated liver disease tend to be judged differently. And my hope is moving forward that that becomes less and less of an issue. Because alcohol-associated liver disease is overall the most common indication for liver transplantation. And again, in younger patients, we are seeing the need for liver transplant skyrocket in patients 20 to 39. And you may or may not be able to see that this ended at 2018. So this was pre-COVID. And we know that this has gotten worse with the COVID pandemic and increased rates of alcohol use disorder. One of the reasons why we're probably seeing more transplants for alcohol-associated liver disease is that more and more centers are performing transplant for alcohol-associated hepatitis. And this paper from the New England Journal from the Franco-Belgian group was published now over 10 years ago and definitely created quite a stir when it first came out. We all thought that they were crazy. What they did was they looked at patients who had severe ALK-HEP who were not responsive to corticosteroids. And they had a very, very selective process to try to choose patients who were likely to do well after transplant. And they were able to find fewer than 2% of patients who were actually eligible for transplant. They did require 100% agreement among team members for candidacy. If we tried to do that here, I can't imagine we'd list anybody. We have healthy disagreements. What they saw was that the post-transplant survival, a little bit less than what we expect after transplant, only 77% at 6 months. But we have to balance that with the risk of mortality in the patients who did not get transplanted. It's almost 80%. So we do have this survival benefit for this really sick, young, generally young patient population. In their cohort, they observed risk of alcohol relapse following transplant of only about 12%, but there was likely an under-detection of relapse. Since that original landmark study, several others have reported on their experience, and I'll summarize some of the results here. So looking at the experience of early transplant, basically less than 6 months abstinence versus standard transplant, the patients do tend to be younger by about 5 years or so. They're sicker. Their MELD scores are in the 30s versus the 20s, and they have increased need for dialysis. They tended to have shorter duration of heavy alcohol use than the patients who were transplanted for ALD who had more than 6 months sobriety. But this may be related to selection bias in terms of the patients who had less alcohol use being deemed appropriate candidates for early transplant. If we look at their survival post-transplant, it's similar regardless of what the sobriety period is prior to transplant. The risk of post-transplant relapse with alcohol use is variable, somewhere between 14 and 34% at 2 to 3 years post-transplant. And daily heavy drinking is associated with mortality. So it is important to monitor these patients because if they are in treatment, both pre and post, their risk of relapse from alcohol use disorder is going to be lower. So we can't just transplant them and say, okay, you're cured, because transplant doesn't cure alcohol use disorder, but we really, again, have to provide them with the tools that are needed for success. I'll talk briefly about the evolution of Medi-Cal coverage of liver transplant for ALK-HEP. So in 1983, there was an NIH consensus conference that came up with the recommendation for the so-called 6-month rule, saying that patients had to be abstinent for at least 6 months because some of those patients may have improvement in liver disease, and it allows you to road test them to make sure they're not going to go back to harmful alcohol use. And Medi-Cal adopted these policies and originally last reviewed it in 1988, which really wasn't keeping up with the state of the data. So in 2020, a petition was sent to the Medi-Cal medical directors by the liver transplant medical directors in California to say, will you at least make some exceptions to the 6-month rule? And they agreed on a case-by-case basis to do this. But there were still issues in getting patients who were approved for liver transplant by the transplant program to actually have insurance coverage. So finally, in February of this year, Medi-Cal has agreed to remove the 6-month rule. So there is now no specific abstinence period required by Medi-Cal, and this is consistent with guidance by the ASLD as well as the Dallas Conference on Alcohol-Related Liver Disease. So we've really made quite a bit of progress over time. Those specific programs still may have different rules, and not every program will choose to forego the 6-month or the 3-month rule. One thing we do have to consider, though, is that liver transplantation for ALK-HEP does have the potential to worsen pre-existing disparities. And I think transplant is one of those places where we do see some amplifying of these disparities, unfortunately, because patients who are older, Black, female, have public insurance or lower level of education or perceived health literacy are less likely to be referred for transplant. And if you look at the papers that have been published on liver transplant and ALK-HEP, the patients are almost overwhelmingly white. The majority are men, and 2/3 had private insurance. And we know that overall Black patients do have less access to transplant. So if we look at the rate of waitlisting relative to the prevalence of liver disease, Black patients really have the lowest ratio. They're also the least likely to be listed for transplant relative to their rate of death due to liver disease. But when Black patients are listed for transplant, they actually do end up getting transplanted at similar rates as the proportion on the waiting list. So it seems like the barrier is really, the referral and the listing for liver transplantation here. One of the issues may be insurance coverage, and we've seen that Medicaid expansion did improve liver transplant access for Black and Hispanic patients, with this map showing the states in blue that did have Medicaid expansion, and the Black and Hispanic patients having more increases in transplant in the Medicaid expansion states. The other thing that's important is patient education, and this was a study that looked at a variety of websites for transplant programs. They found that very few programs had, actually really no programs had educational materials online that reached the understandability level or the easy to understand level. And we know that the websites may not represent all of the education that happens in a transplant program, but it may represent the culture of education at a particular program. But it seemed like the websites of the programs that had more understandable information tended to transplant higher proportions of patients with lower education levels. Now, I think we have a way to go in equity in liver transplantation, and Russell Rosenblatt really laid out nicely a bit of a roadmap. We have to think about what are our areas of focus, Who are the stakeholders involved in this process? And what are the action items that are needed to really affect change? And this, of course, requires money, and it requires resources and other methods of support to really overcome these barriers. I'm going to turn the mic over to Dr. Syed for him to talk about liver transplant surgery with donor selection and intraoperative management.
So there are a lot of things that I could speak about, and I just wanted to thank you again for the invitation to speak. But one of the most important goals for the transplant community is to help as many people deemed appropriate for transplant. Yet, due to organ shortages, the waitlist mortality remains unacceptably high. One of the ways we've attempted to reduce waitlist death is to get livers to those who need it and get it to them as soon as possible. And policy is an important aspect of how to achieve that. And in the recent policy changes, we've attempted to reduce geographic disparities that have been in existence for many years. In the old system, the United States was split up into these donor service areas, which were arbitrarily created areas at the era when kidney transplant was just becoming popular, and before the modern day liver transplant system was in place. And this meant that the average MELD at your transplant center varied anywhere from 35 in region 5 to down to 23 in many regions in the United States. And this significant disparity was sort of unacceptable to the transplant community. But for many reasons, it took decades to come up with some sort of solution to this disparity. And the one that was created and somewhat spearheaded by one of our colleagues here, Ria Hiroshi, is the acuity circles. And this is a prioritization model based on the distance and the MELD score of the recipients based on where the donors prioritize, or where the donors position in the country is. Now, the policy came into effect in 2020, early 2020, and the true outcomes of this policy change have been confounded by the pandemic. And the true understanding of what the policy change has had on the allocation is yet to be known. However, early studies have shown that there's higher MELD patients are receiving more offers and earlier on the match run lists. People who have exception criteria were deprioritized compared to those with higher natural MELDs. And those with lower MELDs were receiving DCD offers, or donation after cardiac death, which are livers that have higher risk of complications. Now, in terms of, the American population is significantly changing, and that means the average donor is changing for us to evaluate. Americans are living longer, and in a study in the New England Journal of Medicine, it predicted that by 2030, nearly 1 in 2 adults will have obesity, and the prevalence will be higher than 50% in 29 states. And nearly 1 in 4 adults will have severe obesity by 2030. And so this has a significant implication on transplantation, as donors with advanced age, high percentage of macrosteatosis, and donation after cardiac death are considered functionally high risk. And that's because of the ischemic reperfusion injury that happens at the time of transplant, and the higher rates of primary non-function as a result of that, ICU stay, days on the ventilator, hemodynamic instability, and acute kidney injury. And so the other major aspect of graft loss in DCD donors is ischemic cholangiopathy, and that's due to the warm ischemic damage that happens to the biliary tree when the cardiac death donor is passing. And so over the years, we've become better at doing surgery. We've been better at doing, performing donors in an expeditious fashion and bringing the livers back to the center in an expeditious fashion. but complications are still occurring at a high rate. And as a result of that, we generally worry about using these donors in patients who are otherwise functionally doing well with HCC and lower MELDs. And it's restricted patients' access to getting these livers. Now, and that results in a high discard rate. Now, what can we do to mitigate some of these risks to get more access to our patients? And one of the newest things on the block in transplantation is normothermic machine perfusion. And there's two machines that have been studied in randomized control trials or randomized clinical trials since 2015. And these machines essentially use blood, an oxygenator, TPN, bile acids, and Flolan to nourish the organ, to promote bile production, and to modulate hepatic artery flow and portal flow while the liver is out of the body. And the liver is placed on the machine at the time of the donor operation. And both of these machines now are FDA approved in the United States. And this image on the right side here, you can see the cannulas going into the IVC, into the portal vein, hepatic artery, and then an outflow cannula from the bile duct. And these livers, you can draw labs of the blood to understand how viable these livers are. So the risk that we used to worry about can be objectified to some degree to give us some more insight about how these livers are going to behave once they are out of the body before being implanted into the recipient. And the preservation times can also be longer. And so at our center, we've done livers on these machines that have been preserved for somewhere between 17 to 18 hours. And in other reports from Europe, people have been preserving these livers for days. Here's the first major publication that was out in Nature in 2018, where 100 livers were randomized to cold storage and 120 to normothermic perfusion. And essentially, they showed that the ischemic reperfusion injury, or the peak AST and early allograft dysfunction, was significantly reduced compared to cold storage. And non-anastomotic strictures in the DCD group, or ischemic cholangiopathy, was significantly lower than standard cold storage. The hemodynamic characteristics that were seen in the operating room once these livers were reperfused were significantly improved compared to cold storage livers. However, that didn't translate into other post-operative outcomes such as ICU stay or kidney injury. A trial in the United States that myself and Dr. Roll, one of my colleagues, was a part of, or were a part of, in between 2016 and 19, where 300 recipients were randomized to the organ care system and cold storage. And the endpoints were similar, that there was a significant decrease in early allograft dysfunction, significant reduction in histopathologic evidence of ischemic reperfusion injury, and a higher use of livers from donors after cardiac death with reduced ischemic biliary complications. Now, many aspects of the post-operative outcomes were not captured as part of these initial trials. However, in this post-FDA approval period, the transplant community, and an effort based here at UCSF to create a registry to further define what the indications for this new technology is, understanding what the benefits, and importantly also what the financial implications of these machines are and the savings associated with them. Because there are a lot of costs and a lot of logistical issues with this type of preservation, like the need for a trained surgeon to go out to the donor hospital, a preservation and a perfusionist to monitor the liver while it's on the machine. So it's a labor-intensive technology, but pretty exciting. another type of preservation that has been studied in Europe extensively and is currently in clinical trials in the United States that we're participating in is hypothermic oxygenated machine perfusion. And essentially, this is a back-to-base type technology where the liver is recovered and brought back to the recipient hospital, cleaned up, and then placed on this machine where there's an oxygenator and standard perfusate being put through the liver for around 90 minutes prior to preservation. So this is significantly cheaper and significantly less logistically demanding, and has shown to have, in a smaller non-randomized study from Italy, to have no evidence or no PNF, no EAD, and a significant reduction in peak AST, which again points to potentially a really significant improvement in outcomes of expanded criteria livers, which would open up a lot more avenues to patients who need it. But this technology needs to be defined and to understand when is the right situation to use each one, or whether these are really significantly better than the current methods that we use. Live donor transplant, again, as Dr. Brandman touched on, is a pathway for patients to get to transplant at lower MELDs. And it's become an accepted pathway to liver transplant for many years. And much of the Southeast Asia and East Asia is the only way to transplant. But due to many factors, the relative adoption in the United States has been lower than in those countries. But despite this, in the United States, we've been involved with innovative ways to improve access for patients who would like to donate but are ABO incompatible with the use of living donor exchanges. So here at UCSF, we did a swap between a living donor kidney pair and a living donor liver pair, where the daughter of a kidney recipient donated to the brother of a kidney donor. And in Toronto, there was a swap which was initiated by an altruistic donor and allowed for an ABO incompatible transplant. And hopefully with some of these innovations in living donor transplant in time, we can increase the trust and standardization between centers to expand this further. And then finally, one of the barriers to donation in the United States or anywhere in the world is cosmetic image changes. Younger donors who want to donate and get back to work quickly and not have a significant interruption in their life. Minimally invasive donor hepatectomy has become popularized in many centers around the world. And in this publication from 2021 in AJT, this center in Saudi Arabia had performed 415 robotic donor hepatectomies and 165 laparoscopic donor hepatectomies with improved cosmesis, less pain, and quicker return to work. And hopefully, in the future, we will be performing such surgeries, and that could aid increased donation rates for live donors. And finally, this is a report of a minimally invasive transplant, which is happening in Korea and in India at the moment, where robotics and laparoscopic implantation is occurring, which even a few years ago would have been deemed completely impossible. It's so exciting to see this kind of work being done. For sure, the jury is still out in terms of if there is real benefit to the recipients, because the implantation times are lengthy and the patients are super selected. But these technical advances are remarkable, and it's exciting to think about what's going to be in the future of liver transplant. And on that note, I just wanted to thank you again for giving me the opportunity to speak, and I'll hand it back to Dr. Brandman.
All right. Thank you, Shareef. Great to hear about all of those exciting technological advances. So I'll conclude the talk just speaking a little bit about long-term post-transplant outcomes. As I mentioned earlier, the advent of hepatitis C therapy has really changed the landscape for transplant, whereas most patients who are getting transplanted would have hepatitis C, would have recurrent infection, and often lose their grafts. Now what we're seeing is that the long-term survival is pretty amazing. At 5 years, survival is about 80%. So even in the past 10 years, we are continuing to see improvements, in part related to hep C treatment, but also improvements in surgical techniques, as well as improvement in immunosuppression regimens. I'll just briefly focus on cardiovascular events, since this is what so many of our patients ultimately die from. And particularly with more and more patients with NASH undergoing transplant, this is becoming a bigger and bigger risk, something we try to screen for before transplant. We know that fatty liver is an independent risk factor for cardiovascular disease. And after transplant, not surprisingly, older age and higher prevalence of metabolic syndrome comorbidities are likely contributors, with diabetes and hypertension increasing the risk of cardiovascular disease by about twofold. And the major adverse cardiovascular events are much more common in patients with NASH as opposed to those who have alcohol-associated liver disease, particularly in the early post-transplant period. And what we see here in this graph is that if a patient does experience a major cardiovascular event, they're unfortunately much more likely to die, which is why we are so stringent prior to transplant in trying to rule out significant cardiac disease. The good news is that if we do the things that we know work, like controlling hypertension, that can actually reduce cardiovascular events. And these are data reported by Lisa Van Wagner at Northwestern, showing that if patients had blood pressure control, that they're much less likely to have a major adverse cardiovascular event, as well as die due to any cause. Unfortunately, very few patients actually had controlled blood pressure in her cohort, even in those who had diabetes and CKD. And while immunosuppression may impact blood pressure and other metabolic syndrome comorbidities, in this study, there was no clear association between immunosuppression type and blood pressure control. Sorry. Also, not surprisingly, statins work. They work in the general population, so maybe not surprising that they work in the transplant population, though certainly they appear to be underutilized. And these are data from the NASH cohort, which we're a part of, that includes patients who've been transplanted for NASH, a multi-center consortium that includes about 938 patients from several centers. And what we saw was that patients who were not treated with statins tended to have poorer survival than those who were treated with statins. And this held true both for patients with and without diabetes. Other studies, particularly a single center study out of VCU, reported similar findings. One of the problems in management of these patients is that it's kind of hard to take ownership over who is the person that is managing metabolic syndrome and cardiovascular risk. So these are survey data also from Lisa Van Wagner that asked a variety of patients, caregivers, and other healthcare providers about who should be educating the patients. And it was pretty universally accepted that the transplant providers should be educating patients about their cardiovascular risk with regard to their transplant status. Unfortunately, there's a lot of variety in terms of the perceptions of who should actually be managing these conditions, with some believing it should be other specialists like a non-transplant provider, or transplant providers, or primary care. I think in reality, we do need more multidisciplinary care for these patients. Behavioral modification is incredibly important, and we developed a program here, me together with two of my nurse practitioners, Lisa Catali and Sarah Miller, that we launched actually during COVID. It's a group telehealth program really aimed at educating patients about fatty liver disease, excuse me, and arming them with the tools to engage in behavior change to help them lose weight and improve liver health. And our preliminary outcomes have been notable for patients self-reporting weight loss, improving their control over their health, and acquiring skills that lead to behavioral change. And we've recently launched this program for our liver transplant recipients with fatty liver disease, and we hope to expand this to more patients within transplant as well as within different disease states. So I'll just conclude with what my wish list is for the future of liver transplantation. I hope that we move more towards more equitable referral and selection of candidates for liver transplantation. And we do need to improve our outreach to communities in need with actual support. We do need accessible, easy to understand educational materials for our transplant candidates, and really universal coverage for transplant for medically appropriate conditions, regardless of insurance type. We need to further improve the supply of donor livers through the novel technologies that Dr. Syed discussed, as well as increasing living donor liver transplantation. And finally, post-transplant, we have to focus on this comprehensive multidisciplinary care for liver transplant recipients to ensure excellent long-term post-transplant outcomes. So I would like to give a big thank you to our massive team, and I can't name all of them, but I work with a great group of hepatologists, surgeons. I was amazed that Shareef was coherent today after doing 2 transplants back to back. We have amazing trainees, APPs, nurses, pharmacists, social workers, administrative staff, really too many people to name. So thank you.
Will come up. So I'll start with a couple of questions and then I'll see if, do we have the other one? Yeah, there we go. Should work. Great. Thank you, that was great. Danielle, you mentioned early on the declining number of listed patients. Is that hepatitis treatment or what's going on there?
Yeah, I think that's really largely accounted for successful hepatitis C treatment, that patients either have cirrhosis and we treat them so they don't have the opportunity to decompensate or develop HCC, or we're treating them and reaching them before they get to the point of having cirrhosis.
Okay. And then maybe to connect the dots, you made the point that the transplant allocation system changed in part because it was so regionally dependent. I assume that means that livers may be coming from further away than they did previously. I assume that means longer time, even with that, I'm sure, very expensive device, getting on an airplane and taking the liver along. So what's the trade-off there of having a liver available, but it's coming from Mississippi to get to San Francisco and it takes an extra 10 hours or something?
That still needs to be figured out, but for sure the initial data has also shown that sharing is further away than it has been. There is more trust within the transplant community about allowing local donor surgeons to perform the procurement for you and then send it, which cuts down the cost to a certain degree. But there are cost implications, travel implications that are leading to longer travels, longer distances traveled by livers. However, if it allows access for higher mild patients who need it in a timely fashion, that will hopefully result in a lower waitlist death rate.
And what are the competencies of a surgeon doing the explant? If it's not you going out to a center and doing it yourself, but can a general surgeon take out a liver, or who does that?
No, I mean, generally speaking, there's been a shift as well in terms of everyone who does donor surgery is generally trained in transplantation or transplant surgery. However, organ procurement organizations, or OPOs, what they're known as, have driven now more to hire their own independent procurement surgeons. So there's, generally speaking, trained transplant surgeons who are competent based on the OPO's evaluation mechanisms to competently remove the liver and then to ship it to you. Can there be issues that arise due to injured vessels and things? For sure there can be, However, as our comfort level increases, our ability to then salvage those grafts by doing reconstructions once it gets to our center is relatively high.
But even if the surgeon is competent, is a patient who comes in with a big varicose bleed and a healthy patient who you're taking the liver out, do they stay at a community hospital? They go to, in other words, is it the surgeon who goes out to a community hospital to do that and the nurses are okay and all the other facilities are okay? Or does the patient have to be at a transplant center to have a liver taken out?
For the donor operation, it will all mostly be done in a community hospital. Again, organ procurement organizations have created specialized donor centers where brain dead patients are transported to these donor centers, which has allowed for more timely donor operations to occur, whereas they used to be pushed to overnight where the elective surgery schedules for the community hospital have been completed, which would lead to very untimely allocation and other recipient operations. This way, with the increase in donor centers, the recipient transplant center has more control of when the donor operation is going to be done.
I see. Okay.
But it's all done in the community.
And then my final question I'll open up is I remember in the early days of living donors, there were some pretty high profile bad outcomes and led to a lot of discussion. How safe is the surgery itself for a living donor at this point?
I mean, it's for sure those, in the United States, the rates are still low, but the deaths that occur after living donation are you can count on your hands after liver donation. Now, the data from Asia and the Southeast Asia has been very very insightful because their numbers are so much higher than we have here, to again show that it's the safety profile has only got better as we've become more competent at doing that procedure.
And it's a portion of what portion? Obviously, you don't take out the whole liver. What portion, and what is their remaining function when they're done?
Generally speaking, they undergo a complex evaluation prior to living donation, which includes anatomic evaluation as well as sizing of the donor graft. And again, as more experience has been obtained, the majority of grafts that are donated are right lobes now. And the residual function usually is excellent because the donors are selected as such that the remaining 40% of the liver is more than sufficient with the subsequent growth to support their.
And we've seen that over 10 years, 20 years that they retain good function.
It's safer than kidney donation, in fact, because the long-term once you're over the surgical course, the long-term outcomes are excellent.
Great. All right. Any questions here? Yeah, and say who you are.
I'm not an adjunct, one of the hospitalists. I had a question. You mentioned more and more younger patients getting transplanted. If that patient is fortunate to be in that group of high survival, what is their what's the mileage you get out of that liver now? Given that they're younger, do they need a retransplant in the future, or how long can that liver last?
So hopefully people could hear the questions for a younger transplant recipient. Will they live to a ripe old age, or does the transplant have a given half-life?
Yeah, I mean, so I think that particular patient group of the young adults, we don't know yet about the long-term outcomes. That being said, the expectation is that they're not going to have recurrent disease unless they return to drinking. 30% of patients who have transplant for any indication other than fatty liver will develop fatty liver. And to date, we haven't seen that much graft loss due to de novo or recurrent fatty liver disease, but I think that is a concern in this patient population. In the pediatric population, we do have some experience, though, the younger patients do run into issues with malignancy. So I think with this patient group, I think it's yet to be seen ultimately what their long-term outcomes will be. But looking at other liver diseases like the cholestatic diseases like primary biliary cholangitis, it is not uncommon to see those patients survive out to 20 to 30 years or so. So my expectation is that if they don't go back to drinking and if we mitigate their cardiovascular risk, that we really are providing a meaningful increase in long-term survival.
And the malignancy issue is something about the transplant or the immunosuppressives or what?
Really the immunosuppression in general, that long-term exposure, yeah.
Okay, I think Lakshmi has some online questions here.
Thank you. So questions from online. You were talking about your transplant wish list. What are potential solutions about addressing at a population level, both alcohol use disorder and obesity, because these are rising population health level problems?
Mm-hmm. Well, that is a very big question. So I think one of the population level things that should happen is really to, I think, which has happened within Medi-Cal, but really making sure that there are no insurance level deterrents to transplant for alcohol-related liver disease, and no regulations imposed by insurance companies that really doesn't match with the modern data. Again, speaking kind of idealistically. I think with regard to obesity management, we just really need societal change in terms of, improvement in food quality, food access, reducing food insecurity, increasing physical activity, which of course is going to help overall health, but, may have an impact on fatty liver disease. So I think that, again, aspirational, but I think we need much more emphasis on behavior modification, because it's been shown over and over again that works for fatty liver and other metabolic syndrome associated conditions.
And last question for Shareef. I think people are still confused about acuity circles because of this old practice of people moving all around the country to increase their chances of getting a liver. Can you talk about the change?
So the acuity circle is dependent on your MELD score, and there's an algorithm based on MELD score at how based on how far you are around these acuity circles, where the offer goes to next. So if you are close to the donor hospital and have a higher MELD score, the offer will go to that person first. If the offer is declined by that person, then it will go to that same MELD score at a diameter further out. If that whole population is then declines, then it goes to that same MELD score further out. Then if all of those higher MELD scores turn the liver down, then it then returns back to the donor hospital, and then works from a lower MELD score and then offers it to that patient population at that MELD score, and then works its way out again 3 times over. And there's an algorithm based on the closeness to the donor hospital and your MELD score, and then the algorithm keeps running. But essentially, it gives greater access to those with higher MELD scores closer to the donor hospital. Now, the dual listing issue is one that's sort of a longer answer, but I can for sure reach out to whoever has asked that question and answered that for them.
But is the impetus for what we used to hear about people who of means traveling to a different part of the country, the impetus or the incentive to do that is lower than it used to be?
Lower than it's used to be, but it's still present.
Yeah. When we say the organ has declined, just nobody within that circle who's eligible, or people will decline it? Are there other reasons why you would decline it?
Just for organ quality or size or patient not ready. There's many reasons why transplant centers will decline a liver for that particular recipient, which are for all of those reasons that I spoke about.
Time for one more. Anyone? All right. Fabulous. Thank you. That was terrific. And thank you for the amazing work you guys do. Appreciate it.
Thank you.